Calcium oxalate kidney stones, prevention, thiazide citrate, and dietary management. Calcium oxalate kidney stones are the most common type of kidney stone, affecting approximately 10% of the population. Prevention involves dietary modifications, thiazide diuretics, and citrate supplementation. The primary mechanism is hypercalciuria, which can be managed with thiazide diuretics and dietary calcium restriction. Key points. Note: calcium oxalate stones account for approximately 70 to 80% of all kidney stones, with a prevalence of 10 to 15% in the general population. Thiazide diuretics, e.g., hydrochlorothiazide 25 to 50 mg/day, reduce urinary calcium excretion by 30 to 50%, thereby decreasing stone formation risk. Citrate supplementation, e.g., potassium citrate 10 to 20 milliequivalent/day, increases urinary citrate levels, which inhibits calcium oxalate crystallization. Dietary calcium restriction, to 2g/day, is recommended for patients with hypercalciuria, but excessive restriction may increase oxalate absorption. Urinary calcium excretion greater than 250 mg per day is a key diagnostic criterion for hypercalciuria, which is a major risk factor for calcium oxalate stones. The 24-hour urine test is the gold standard for diagnosing hypercalciuria, with a cutoff of 250 to 300 mg/day. Patients with recurrent calcium oxalate stones should undergo a stone analysis to guide individualized management. The American Urological Association, AUA, recommends thiazide diuretics and citrate supplementation as first-line therapies for calcium oxalate stone prevention. Overview and epidemiology. Calcium oxalate kidney stones are the most prevalent type of kidney stone, accounting for approximately 70 to 80% of all urolithiasis cases. The global prevalence is estimated at 10 to 15%, with a higher incidence in men than women, particularly in the 20 to 40 age group. The condition is more common in individuals with a family history of kidney stones, recurrent urinary tract infections, or metabolic disorders such as hypercalciuria. Risk factors include a high sodium, high protein, and high oxalate diet, as well as conditions like hypertension, diabetes mellitus, and chronic kidney disease, CKD. The incidence of kidney stones increases with age, peaking in the 5th and 6th decades of life. The condition is also more prevalent in certain ethnic groups, with higher rates observed in Caucasians compared to African Americans. The economic burden of kidney stones is significant, with annual healthcare costs exceeding $10 billion in the United States alone. The primary goal of management is to prevent recurrence through lifestyle modifications, medical therapy, and dietary interventions. Pathophysiology. Calcium oxalate kidney stones form due to a combination of hypercalciuria, hyperoxaluria, and low urinary citrate levels. The primary mechanism involves the supersaturation of urine with calcium and oxalate, leading to crystallization and stone formation. Hypercalciuria, defined as urinary calcium excretion greater than 250 mg per day, is a major risk factor for calcium oxalate stones. This condition can result from various causes, including idiopathic hypercalciuria, renal tubular acidosis, or excessive dietary calcium intake. Hyperoxaluria, characterized by urinary oxalate excretion greater than 40 mg per day, is another key contributor to stone formation. Oxalate is primarily absorbed from the gastrointestinal tract, and its excretion is influenced by dietary intake, intestinal absorption, and renal handling. Low urinary citrate levels, typically less than 30 moles/day, further predispose to stone formation by reducing the inhibitory effect of citrate on calcium oxalate crystallization. The pathophysiology is also influenced by urinary pH, with acidic urine, pH less than 5.5, promoting calcium oxalate crystallization. The interplay between these factors determines the likelihood of stone formation and recurrence. Understanding these mechanisms is essential for developing targeted prevention strategies, including thiazide diuretics, citrate supplementation, and dietary modifications. Clinical presentation. Calcium oxalate kidney stones typically present with acute flank pain, often described as colicky and radiating to the groin. The pain is usually severe and intermittent, associated with nausea, vomiting, and hematuria. Patients may also experience dysuria, frequency, or urgency due to ureteral obstruction or irritation. The majority of patients present with unilateral flank pain, which may be accompanied by costovertebral angle tenderness on physical examination. In some cases, the stone may pass spontaneously, leading to relief of symptoms within hours to days. However, if the stone becomes lodged in the ureter, it can cause hydronephrosis, leading to progressive renal dysfunction. Atypical presentations include recurrent urinary tract infections, chronic flank pain, or asymptomatic stone passage. Red flags requiring urgent attention include hematuria with flank pain, fever, or signs of sepsis, which may indicate complications such as pyelonephritis or septic embolism. The presence of these symptoms necessitates prompt imaging and urological evaluation to determine the stone location and size, guiding further management. Diagnosis. The diagnosis of calcium oxalate kidney stones is based on clinical presentation, imaging, and laboratory findings. A 24-hour urine test is the gold standard for diagnosing hypercalciuria and hyperoxaluria, with urinary calcium excretion greater than 250 mg per day and urinary oxalate excretion greater than 40 mg per day being key diagnostic criteria. Urinary citrate levels should be measured, with a target of greater than 30 mol/day to inhibit calcium oxalate crystallization. Urinalysis may reveal hematuria, white blood cells, or crystals, which can help confirm the diagnosis. Imaging modalities such as non-contrast computed tomography, CT, are the preferred method for detecting kidney stones, with a sensitivity of over 95%. CT can also assess stone size, location, and complications such as hydronephrosis. Ultrasound is an alternative for patients with contraindications to CT, although it may have lower sensitivity for small stones. The presence of a stone on imaging, combined with clinical symptoms, confirms the diagnosis. Differential diagnoses include urinary tract infections, renal colic due to other types of stones, and urological abnormalities such as ureteral strictures or tumors. Validated scoring systems, such as the Mayo Clinic Risk Score, can help predict the likelihood of stone recurrence and guide preventive strategies. Management and treatment. The management of calcium oxalate kidney stones focuses on preventing recurrence through lifestyle modifications, medical therapy, and dietary interventions. First-line therapy includes thiazide diuretics, such as hydrochlorothiazide, 25 to 50 mg/day, which reduce urinary calcium excretion by 30 to 50%. Thiazide diuretics are particularly effective in patients with idiopathic hypercalciuria. Citrate supplementation, such as potassium citrate, 10 to 20 milliequivalent/day, is recommended to increase urinary citrate levels, which inhibits calcium oxalate crystallization. The target urinary citrate level is greater than 30 mol/day. Dietary modifications are essential, including calcium restriction to 2 g/day, sodium restriction to less than 2.4 g/day, and increased fluid intake to achieve a urine output of greater than 2.5 L/day. Patients should also limit oxalate-rich foods, such as spinach, nuts, and chocolate, to less than 150 mg per day. For patients with recurrent stones, a 24-hour urine test is recommended to guide individualized management. Second-line therapies include calcium-based binders, such as calcium carbonate, which can reduce oxalate absorption in patients with hyperoxaluria. In cases of refractory hypercalciuria, loop diuretics such as bumetanide may be used. Special populations, such as pregnant women, require careful consideration, as thiazide diuretics are contraindicated during pregnancy. Instead, citrate supplementation and dietary modifications are preferred. In patients with chronic kidney disease, thiazide diuretics should be used cautiously due to the risk of hypokalemia and volume depletion. Guidelines from the American Urological Association, AUA, and the National Kidney Foundation, NKF, recommend thiazide diuretics and citrate supplementation as first-line therapies for calcium oxalate stone prevention. Monitoring parameters include regular assessment of urinary calcium, oxalate, and citrate levels, as well as renal function and electrolyte balance. Complications and prognosis. The complications of calcium oxalate kidney stones include acute renal failure, chronic kidney disease, and recurrent stone formation. Acute renal failure can occur due to severe obstruction or infection, with an incidence rate of approximately 5 to 10% in patients with large stones. Chronic kidney disease is a long-term complication, with an estimated 10 to 20% of patients developing progressive renal dysfunction over time. Recurrent stone formation is common, with a 50 to 70% risk of recurrence within 5 years. Prognostic factors include the presence of hypercalciuria, hyperoxaluria, and low urinary citrate levels. Patients with recurrent stones should undergo a stone analysis to guide individualized management. The risk of complications is higher in patients with comorbidities such as diabetes mellitus, hypertension, and chronic kidney disease. Referral to a urologist is necessary for patients with recurrent stones, complications, or refractory hypercalciuria. The prognosis is generally favorable with appropriate management, but long-term follow-up is essential to prevent recurrence and monitor for complications. Special populations and considerations. In pediatric patients, calcium oxalate stones are less common but can occur in children with hypercalciuria or metabolic disorders. Management includes dietary modifications, thiazide diuretics, and citrate supplementation, with careful monitoring for growth and development. In geriatric patients, the risk of complications such as acute renal failure and sepsis is higher, necessitating prompt imaging and urological evaluation. Pregnant women require special consideration, as thiazide diuretics are contraindicated, and citrate supplementation and dietary modifications are preferred. Patients with chronic kidney disease, CKD, should be managed cautiously, as thiazide diuretics may exacerbate volume depletion and hypokalemia. Drug interactions are important to consider, such as the potential for thiazide diuretics to increase lithium levels or reduce the efficacy of antihypertensive medications. Monitoring parameters include regular assessment of urinary calcium, oxalate, and citrate levels, as well as renal function and electrolyte balance. Individualized management is essential to optimize outcomes in these special populations. Clinical pearls. Note: calcium oxalate stones are the most common type of kidney stone, with a prevalence of 10 to 15% in the general population. Thiazide diuretics, e.g., hydrochlorothiazide 25 to 50 mg/day, reduce urinary calcium excretion by 30 to 50%, decreasing stone formation risk. Citrate supplementation, e.g., potassium citrate 10 to 20 milliequivalent/day, increases urinary citrate levels, inhibiting calcium oxalate crystallization. Dietary calcium restriction to 2 g/day is recommended for patients with hypercalciuria, but excessive restriction may increase oxalate absorption. Urinary calcium excretion greater than 250 mg per day is a key diagnostic criterion for hypercalciuria, a major risk factor for calcium oxalate stones. The 24-hour urine test is the gold standard for diagnosing hypercalciuria and hyperoxaluria, with a cutoff of 250 to 300 mg/day for calcium. Patients with recurrent calcium oxalate stones should undergo a stone analysis to guide individualized management. The American Urological Association, AUA, recommends thiazide diuretics and citrate supplementation as first-line therapies for calcium oxalate stone prevention. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.